All right, here we go. Thank you so much for joining us. We are joined here with Dr. Costello, and he is going to be filling in on the second portion of our discussion for virtual and community practicing during the opioid epidemic. And if you joined us for our first half, you got a chance to hear from multiple perspectives on what's happening during this time. I first want to say thank you so much for waiting patiently as we got ourselves together so we can present during the second half. And I want to talk about Dr. Costello and his work. He is a clinical psychologist and is with UC Berkeley Social Services Unit, where he specifically works with Cal students who has it been 5 years? Wow, time passes. Prior to that, he was the program intake coordinator at a harm reduction psychotherapy clinic, the Center for Harm Reduction Therapy, which is a nonprofit community mental health program. And he was there for 8.5 years. So he's provided therapy for individuals, couples, families, groups, in many different settings, and among them, the Homeless Youth Alliance for Transitional Aged Youth in the San Francisco Haight area. So he's got a multitude of knowledge and experience that he's going to share with us today on how to support the many individuals who are struggling with substance abuse during this pandemic. So without further ado, we're going to welcome Justin or Dr. Costello to our discussion.
Hey y'all, wonderful to meet you, and thanks for having me. And it was wonderful hearing the first part too. It was great to hear so many like-minded folks talking about how they're serving a lot of people during this challenging time. So I'm really happy to be here and talk about my piece of that as well.
Amazing. I would love for you to start with first just talking a little bit more about your experience in the field and how did you end up working with the substance abuse population?
Sure. So again, my name is Dr. Justin Costello. I'm a clinical psychologist and my pronouns are he, him, and his. I have been working in the field for quite some time. I went with our wonderful moderator here, as well as Michelle, to CSPP in San Francisco Bay for my graduate program. And while there, I was drawn to there because of the multiculturalistic focus they had, and they tried to, they did their best to give lip service and walk that talk as well. I was drawn there to do research around same-sex couples to try and bring about more rights, equal opportunities for folks there in regards to marriage and other specific rights. And so kind of from that social justice angle, I was also drawn to trying to work with as many folks as possible that many other providers might sometimes have a higher threshold for or turn away depending on their circumstances. And so that started with me working in the Tenderloin and going to the Harm Reduction Therapy Center, now known as Center for Harm Reduction Therapy, initially as a practicum student. And then they liked me and I liked them, and I love the folks I was working with. And so then I became my postdoc in there as well. And then I got employed and stuck around for a while. And now I'm with Berkeley and always working from that harm reduction lens, which I'm really excited about. And I'm happy to talk more about what exactly that means. So you got a nice piece of that already. So.
Oh, awesome. I think as you're, talking about what you've done and your experience, one thing that stands out is how important language is and describing the population that you're working with. And I'm wondering if you can speak a little bit to the difference between addiction versus substance use and clarify that for our viewers.
Absolutely. Wonderful question. So part of being a harm reduction psychotherapist related to substances and in general is recognizing that language is important and can carry a certain stigma. Substance use is one of the categories in which people still feel like they can be justified or have a double standard as far as using certain derogatory terms. Mm-hmm. Now, like any other intersecting identity, different terms might hold power for different folks, and they may want to refer to themselves in certain ways. But for other folks, it can be like a way of perpetuating a very oppressive system. Mm-hmm. So, for example, substance use versus substance abuse or dependency, part of that is recognized from a clinical perspective now that in the DSM, the manual that psychologists and other providers use, abuse and dependency, those aren't terms that aren't used anymore, partially for the terms that were seen as more stigmatizing and partially because they're not as clinical. Now they say substance use disorder. But even beyond that, as other folks who've already spoken to made mention of, not everyone necessarily sees their relationship with the substance, even if it is causing negative consequences, as a disorder or meets the criteria for a diagnosis. And then other terms that are a little bit more weighted, like say, addiction still gets used in the literature a lot, but addict, for example, junkie, pothead, meth head, things like this, these are all terms that you might be akin to like a homophobic or a racial slur if you're thinking about the intersected identity of a drug user. And I really like to normalize for people and say, you know, we all are drug users. We all use drugs. I mean, you know, yesterday was National Dessert Day, right? I don't know if you all observe that national holiday or not, but like if you're eating sugar from a young age, if you're having any food that's processed and it's got high fructose corn sugar in it, if you drink your coffee in the morning, like we all use substances. It's just about how's that working for the person? Do they need to make adjustments? Are they experiencing negative consequences to their personal, professional, academic life, physical health, things like that? So we really try to meet clients where they're at, make adjustments where they feel it's important to them, but we don't assume we know it's best for them, as other people are speaking to.
No, I think that's amazing that you're bringing that up, because it definitely normalizes all experiences, which I think those who have been using substances don't always feel like their experience has been normalized. And also pointing out the shift from using substance abuse and DSM to substance use disorder, I think was a significant one to really work on destigmatizing. So I really appreciate you pointing those things out, which also means as clinicians, we need to make sure that we're not using the old terminology, which is creating more stigma, and using the new terminology and more positive ways to try and reduce the stigma that fortunately is out there right now. So thank you for pointing those out. And I'm wondering if you can also speak to what does substance use look like, specifically the opioid use. With everyone being, you know, virtual, are there particular things that we should be looking out for as well?
For sure. So since COVID's happened, since people are sheltering in place more, not everyone, but many people, they're drawn to substances, and they're drawn to opiates in particular when they are socially isolated. So I often try to think of substances also as kind of like a relationship. Sometimes it's a person's primary relationship. So if you think of your relationship with a substance kind of like a relationship with a person, it can be positive at times, it can be negative at others, it can be love-hate. And so if you're left alone with your own thoughts, and you're feeling lonely and isolated, you might be more inclined to want that companionship, to have something to fill the time. Sometimes it's just to feel boredom when you don't know what to do with yourself. Sometimes it's more anxiety and depression and self-medication. We know that people use substances for all kinds of reasons. Sometimes it is just to relax or unwind. Sometimes it's to celebrate or commemorate something. Sometimes it's for ritualistic purposes or within their own personal cultural traditions. Sometimes it's to self-medicate physical or emotional pain. It's not good or bad or right or wrong. It's like, how's it working for that person, and how do you make them make changes around it if they're wanting to and feeling ready to?
Which is really helpful, a helpful distinguishing point. And I'm also wondering if you can speak a little bit to the difference between what is functional use versus dysfunctional use, and how as clinicians we should be looking for those signs.
Yeah. So that can look very different for many people. Some folks, they might feel like, well, hey, if I'm getting rent paid and I'm keeping this roof over my head and I'm making sure my family's getting fed, I'm very functional. Meanwhile, it could be on a physical level, really doing a number on them and deteriorating their body over time. We try and look at the whole person and the whole picture. We don't see substance use as just biological. Often the disease model focuses a lot on the biological and the physical, and that is very important, but it's just one piece of the puzzle. So we use this biopsychosocial model that recognizes how does this substance impact you physically based on dose and how often you're using it, if you're cross-fitting with other substances. What you're bringing to the table physically, sure, genetic precursors can play a part, but more like, are you recovering from a cold or a flu or some other kind of illness? Have you had food or water this day? Are you sleep deprived, right? And then there's the psychological component for biopsychosocial. That's your emotional state at the time and how the substance impacts you. And then social for biopsychosocial. This one's huge, but people don't think about it as often. This is social, cultural, and environmental factors. Are you in an environment that feels safe and familiar versus one that's more disorienting? Are you around people you know and trust versus not? What are their expectations of you around use and vice versa? And then your own personal image of yourself, how you want to be perceived by others based on all your intersecting identities. So we try and look at all these things. If they're more in alignment, you might be more likely to have a positive or neutral experience with your substance use. If any of them are out of alignment, you might have a more negative experience.
Awesome. I mean, it's really helpful to have that framework when thinking about working with your client who might be experiencing substance use disorders, and then also thinking about how functional they are in their day-to-day life. Because I imagine there's the lens from the client view, there might be the lens from the family view, who they're saying, yeah, they're not functional, but the client is like, I'm totally functional. And then also having the clinical view of whether they feel that it's functional or not. So really describing the differences, I think, is quite important, and to work with the client and their views on how it's going for them. I'm also just thinking about, in your response, how both Mike and Laura from the first panel discussed some of the harm reduction strategies that they've used within the community, especially about creating an empathic and open and caring environment. Can you share a bit more about the harm reduction model and the strategies that you've used?
Yeah, absolutely. So speaking more to the model specifically first, we try and think about harm reduction as almost like a tree with like multiple branches, right? One branch might be the public health piece. You know, that can be things like safe consumption sites and other needle exchanges and things like this. The other piece might be the clinical piece, the therapeutic relationship or group therapy, treatment centers, things like that. And then there's the social justice piece. And that's getting to what folks were talking about before about the drug war and the systemic oppression that's been happening over multiple generations, and recognizing that this has been used as a way to oppress certain classes. And so trying to be mindful of that, and by doing harm reduction therapy, accepting a person for who they are and trying to recognize that, meet them where they're at, be trauma informed, you are engaging in a form of social activism in a way. Because so many other treatment programs will say, no, you got to get the substance use thing under control, and then maybe we'll talk about giving you other support, or we got to just focus on the substance use and get you to what they would say is abstinence or clean and sober, and there's no other in between there. If you're able to have that more flexibility to lower that threshold to meet the person where they're at, to tailor the treatment to their specific needs, that's a form of social activism in a lot of ways. And then you can actually be more active as far as your other guest spoke to, trying to write legislation or encourage new policies and things like that too. Part of my required viewing for one of the classes I teach on harm reduction groups and teaching how to do groups for substance use disorders for students who are wanting to learn about that is watching the documentary 13th. Many of the folks here tonight probably have already seen it on Netflix. You can watch it free on YouTube if you don't have Netflix, but it really breaks it down for you. And doing the work from that context, remembering that people have experienced intergenerational trauma, and that's where many people, not all, but many may be coming from, and trying to address that accordingly can help a lot too. Oh, and as far as specific strategies, I should also say we can help people make adjustments as far as the amount that they're using, the times of day that they're using, if they're interested in feeling motivated and ready to do that. We help them come with alternate activities lists, like little cheat sheets they can refer to if they feel like they want to try and fill time and avoid use or reduce use. As other people said, if you don't give something to replace what they're experiencing and they don't have other ways to self-soothe, then ultimately, you know, it doesn't feel sustainable, and it's not really fair to the person if this has been their primary coping mechanism for a long time.
Right. And with that, you know, thinking of harm reduction, I'm wondering if you can speak a little bit to some of the controversies that exist regarding the model.
Yeah, I'd be happy to. So often people try to put harm reduction and abstinence-based treatment, and often 12-step, because that one's been around for a long time and gets a lot of press, in a dichotomy, and they're really not. Harm reduction is a continuum that can include abstinence and can include 12 steps. So on one end of that continuum, you have abstinence. You try and not use any substances entirely if that's what your goal is, or engage in different behaviors too. The other end of the continuum is using all kinds of things, experimenting with different substances, but trying to reduce risk and harm when you're doing so. And then anywhere in between, you've got folks who are trying to moderate and folks who are trying to avoid certain substances while using others. The important thing really is just recognizing that there's no only one way to do this. As other folks spoke to, you're working in a partnership with the person. You're trying to figure out what feels best for them. They ultimately get to have the self-determination to decide what changes, if any, they're going to make. Doesn't mean you're not a human being that has your own feelings, your own concerns. You're about your clients. You might be wishing they're doing certain things, but that radical neutrality and holding it with them, meeting where they're at, is what helps them come to that point as it feels appropriate. Using motivational interviewing, using the stages of change, and helping people recognize where they're at with that can be really helpful.
Well, and I also wonder, coming from as well as a clinical perspective, like many clients who are kind of hitting what we call rock bottom with substance use disorders are looking for treatment, and they're looking for help because they don't feel like they know what to do. And I think there's so much rhetoric around abstinence that if they're coming into treatment and we're telling them, oh, well, you just need to stop, that's not going to bode well.
Yeah.
So really also supporting that dialogue and helping the client see that abstinence is one end of the spectrum. That's not necessarily what they need to jump to.
Sure. And for some people, that is the right choice, but not everyone. And part of the issue with that, too, of course, is you're setting them up for failure, feelings of stigma and shame, because if they're saying, oh, this is the only way I can be successful, and they haven't done the preparation to get there, or they're not really fully interested in that, their body, their mind, their heart, their life, it's not feasible, then when it fails, it's not like the system's messed up, I'm not getting the support I need. It's what's wrong with me? Why can't I do this? Other people can, you know?
Right. And that is significantly important, because then it just becomes the cycle. Like, if something's wrong with me, then I use more. Such great points. And I'm also just wondering, you know, right now, as we are doing all of our work virtually, how has it been for you, you know, practicing and doing telehealth with individuals who are individual clients who are struggling with opioid use?
Yeah, it can be challenging at times, for sure. There's some clients I see via phone. There's some I see via Zoom. And I lead a harm reduction group at the Tank Center at UC Berkeley via Zoom as well. And it's kind of a mixed bag. There are some clients who have agoraphobia and have social anxiety and probably never attend the group otherwise, and so this is actually more comfortable for them. They can turn their screen on and off when it feels comfortable, depending on the group guidelines and such. Other folks, they really feel like something's lacking. Like, while they get a lot of good support from the group, and it's much better than having no contact, it's harder for them to not be in the room with somebody. And for us as clinicians, we have to be careful as far as still trying to monitor the person's safety. And when they consent to telehealth, they also consent to giving us their contact information so we can send out emergency services to them if necessary. You know, if we know they are actively using opiates, we have conversations with them about naloxone and talk about how to facilitate getting some for them. But, you know, this COVID, it's really tricky, because one of the greatest harm reduction strategies is either through a consumption site or through friends, is using with other folks so that you're not alone in case something doesn't go quite so well. And that's happening less now.
Right. That is a very tricky situation. And I'm also curious, given that we're in this pandemic, would you say that you've noticed an increase in those seeking support for substance use? Or would you say it's like still about the same?
Well, I think we have had an increase, and beyond just having an increase, we've had more chronic or intense need from folks that we were already seeing. So, like, normally what we use at Cal is a short-term model. We work with students for a semester on average, but a little bit more or less depending on need. And then they might join the group and continue to do that, or get connected to some community for long-term care. A lot of my folks that I might have only just worked a semester with, I've held through, like back in the spring, I've held through the summer and into the fall when I've had capacity, because they could really benefit from it. And back to this biopsychosocial piece, social, cultural, and environmental factors are kind of like completely off the wall right now. People are at home with their families when they didn't expect to be. And sometimes that's supportive, but sometimes that adds to their stress and makes it really uncomfortable for them. And they have less, patience and contact. One of the other things I do for work is working with survivors of sexual violence, partner violence, stalking, and harassment. And sometimes that can go hand in hand with substance use, but not always. And as a result of that, people are sometimes being trapped or forced into environments with either partners or family members that they would prefer not to be. And so sometimes they might use substances to cope with that, or sometimes that family member is using a substance that is making it harder for them too. And that's part of the work we do too with students, is we'll support them around if they have concern to a friend or family member as well. So.
Amazing. And would you say that you're noticing increases? I would ask this way. Would you say that there's a difference in terms of those who are increasing their need based on whether it's opioid use or alcohol consumption, or is it just across the board that you're seeing increases in need?
Definitely seeing increases across the board. And we have seen more folks who are coming in for support on opiates specifically. Now actually more open to considering opiate replacement treatment. So we've gotten more people connected to Subutex or Suboxone through local clinics because, just going out to get, a drug to self-medicate or otherwise is a risk now. And so having a more consistent option, it can be helpful for folks. So it's, it has been challenging in a lot of respects. And I think a lot of people are still really appreciating the support that they're getting. But it's all the life stressors of being forced to do everything remotely now. All their classes, they had paid for the semester. They're expecting to see people face-to-face, professors, everything else. It just kind of, it's a lot to ask for anyone to have to deal with. And, back before I was working here, I was working community programs, and I had folks kind of from all walks of life as well, folks who were trying to figure out where they were going to sleep that night. And so sometimes people use substances, not opiates necessarily, as a form of survival or self-preservation. It's like, I don't feel safe at night. I sleep during the day when I can sleep in an open place that's safe. At night, I need to stay awake, so I'm going to take something to keep me up. There's all kinds of adaptive things that people do for themselves. So.
And I think from a clinical standpoint, it's really understanding that versus making the assumption that they're using substances to abuse them, so to speak.
Yeah.
And I think that is not just with the stigma, this misconception of why people use and not seeing the trauma or sometimes intergenerational trauma that can be a major factor. I'm just, thinking about your work, I'm wondering what considerations you think there should be for clinicians in terms of them being aware of working with this populations.
Yeah.
And forgive me, I think my language is starting to go downhill just because.
No, it's totally fine. That's the thing. This stuff takes practice because we've been so inundated by certain terms in the popular culture. So I totally get it. So yes, I think one of the things is back to this idea of stigma attached to substance use, and often society at large, and even sometimes providers, whether that be medical doctors or therapists or otherwise, can feel a little self-righteous. It's like most of the time you've got this thing called transference and how the client sees and interacts with you, and you've got this thing called countertransference and how you interact with the client and what things get brought up for you. And we try and be aware of that and keep it in check and have it not potentially do harm to the client. But we kind of sometimes give ourselves a pass when it comes to substances. We justify it by saying, oh, well, we got to keep them safe physically, so I can tell them whatever I want. If I think they should stop, I'm going to say I think they should stop. If I don't feel comfortable working with them because they're actively using substances, I'm going to say there's the door. And I am here to challenge my fellow clinicians to say that it's okay to feel that way, to have those initial impulses, but to say, wait a second, I need to hold myself to the same standard on this that I would for any mental health concern. And if I'm not telling a person what they have to do and being as directive with them based on that condition, why am I doing it with this one? And consider getting supervision if you need it or extra support, but and stay aware of that countertransference, but don't think that it gives us permission to treat them differently or less than, which can sometimes happen intentionally or otherwise.
Right. I think that's an absolutely brilliant point. And just wondering, you pointed out supervision, and I'm thinking about ethics in terms of staying within your lane and practicing within your scope of knowledge. But given that where we are right now, some of these issues are creeping up in clients that we've been serving where maybe this has been an underlying issue that has become exacerbated with COVID. So definitely seeking supervision or consultation and just reaching out and collaborating with colleagues to continue to provide that support. And most importantly, it sounds like you're saying sit with yourself first and think about your reaction and why that's coming up for you before making a judgment or an action, which,
absolutely.
I highly believe.
Sorry,
No, go ahead.
And in addition to the supervision and the consultation is like educating ourselves too. Staying up to date on the latest research related to it, reading different resources on how to practice harm reduction, how to use trauma-informed care, using things like motivational interviewing and non-judgmental speech and everything else, trying to be mindful of their stage of change as opposed to impose or where we think therapy should go, goes a long way. So, yeah.
And can you speak to the multicultural considerations in terms of how we should be thinking about supporting clients and substance use? Because we know that there are disparities in terms of treatment and access with various ethnic cultures, particularly African American, as Laura pointed out earlier in the discussion. But I'm wondering if you could speak to both your experience and your thoughts on how clinicians can be more mindful.
Sure. Yeah, those disparities exist, unfortunately, and with good reason, and by design in many cases, right? If you look at our history, you know, and again, the documentary 13th touches on this some, like there is a history of actually experimenting on certain populations, folks, right. People of color, you know, and so often people say, oh, you don't want to see the medical doctor, you don't want to take this medication, what's wrong with you? You're just being paranoid. It's like, no, I have a healthy paranoia. I can't trust these systems anymore. And so I'm going to learn how to take care of myself, and sometimes that involves self-medication as well, whether that be using a certain substance or taking medication not as prescribed because you feel that feels safer than this institution over here. So recognizing that's where a person may be coming from, taking the time to build that trust and rapport with them. If you have psychiatric staff that is part of your team, doing a warm handoff and introducing them, doing a lot of prep work with them and processing their feelings about whether they want to meet with this person and consider options, letting them know they can just talk to them about choices without actually having to take any medications if they don't want to, and weighing all the pros and cons of it, because medications aren't for everybody necessarily. So being really patient, being mindful of the cultural context is super important. And just recognizing that, you know, from a purely harm reduction perspective, it's not just about the biological component, it's also about the legal component, because we know that there's huge disparities there too. So if a person's going to be using their substance for whatever reason and they're holding and they're walking around and they get stopped by law enforcement, not only is their life potentially in danger, but if they manage to survive the incident, they could be going away for a much longer time period. So being mindful of that, giving a person a space to process and discuss that, in an environment that's non-judgmental and recognizes that cultural context, and talking about ways to actually make safety plans and problem solve around that too.
I think that's super valid, and I appreciate you bringing up the, you know, carrying substances on their person and the potential risk that creates, and also just the idea of creating that space to discuss how they may use, or like creating a plan. Right? If you are holding the substance, you know, you want to make sure that you're aware of all of the risks. And I also think that those risks extend to clinicians, which are some of the reasons why clinicians might fear working with this population, because they're not sure, what if my client overdoses? And it's very similar to working with suicidal clients, where there's an initial reaction of like, too much risk here. And I'm wondering what thoughts you can share with them in terms of helping them overcome that and realizing that the individual needing the support is just that, an individual needing support.
Absolutely right. Yeah, I mean, anytime we work with somebody around mental health, and I think the substance use, not in all cases, but a lot, is also mental health issues. It's not just what's the substance use about, what's the biological components, like what's happening on a psychological level behind that drives a person to use this as a way to cope. I think just remembering that, yeah, there's risk involved with that. This is kind of what we signed up for to a certain degree. It's not for everybody. There are some folks who ultimately decide this is the kind of work that I don't feel ready to do. And I would say, before we jump to that conclusion, challenge yourself, know that you're not having to do this by yourself, that ideally you can do it as a team, even if you're in a private practice, making sure that you have other potential support systems and supervision and things like that. And then just, you know, being kind of radically accepting and neutral doesn't mean you don't still have your opinion. So as other people, I think, said, if you have concern about a person's safety, you can let them know that, but you want it to come from a place of genuine care and curiosity, as opposed to assumption that you know what's best for a person and that they have to make changes. You know, so so you still make safety plans, you still anticipate potential dangers, physical, emotional, legal, otherwise, and you want to do your best to try and keep a person safe in any way they can possibly be. But think the thing I'll say to that is, like, if you don't work with them or somebody else doesn't work with them, their odds go up much higher, right? And there's research that shows this too. You know, people with mental health and mental illness conditions, people with substance use disorders, everyone assumes, oh, well, they're violent, they're scary, they're dangerous, we need to avoid them. Where research actually shows statistically that they're more likely to be survivors of an incident, a physical assault, a crime. Their mortality rate goes up by being in those categories. They're not putting other people at risk to the degree that society tries to convince us.
Yes, I mean, I think there is, oh God, it's been so long. I'm not even 100% sure, don't quote me on this, but I believe there is an IAT test or iatrogenic test that was put out in terms of who fits the model of a substance at the time abuser, and just the imagery that was used was, you know, kind of shocking. But in terms of identifying which populations or which ethnic groups are more likely to be abusers or users, there was definitely, you know, a default. And so
or more likely to be profiled as a user or abuser. Yeah.
Right. So I think you're spot on in terms of really speaking to clinicians in terms of changing our language around how we describe those who are using, and two, really thinking about our own reactions and thoughts of who is using, so that we can really focus on the individual and not our own assumptions of what the individual should look like. I'm going to deviate just briefly, and I'm curious if you can speak to or provide suggestions for those who are watching on how they might get into this area, if this is something that they're interested in, or who they could reach out to if they're needing consultation or supervision around such issues.
Yeah, great question. So where I used to work prior to here, before I come into Cal, the Harm Reduction Therapy Center, also goes by Center of Harm Reduction Therapy, depending on whether it's their private practice or their community program. They have great training, supervision, and consultation opportunities. So if you're wanting specific supervision around working with individuals around substance use and mental health, or groups, they have like a group supervision that they can offer, which is pretty fantastic too, where you actually get to be in a group with other providers and get the sense of what it feels like to be in the group and have process and experience that dynamic and discuss what's happening in the room, as well as bring up cases and get consultation around that too, which can help with your empathy of what it feels like to be in the scenario that your clients are in. In addition to that, you know, kind of more basic trainings, Harm Reduction Coalition has resources as well in Oakland. But yeah, the ones I'd really recommend is Harm Reduction Therapy Center. They have San Francisco and Oakland offices, and they have all kinds of training, supervision, workshops, and consultation and things like that. So
amazing. And I'm sure that resource will be posted in our chat or available afterwards.
In my supplemental information, I also include like literature related to this too. There's an article that folks from that center wrote, and some different books and things like that. Some self-help ones for clients who are wanting to do harm reduction psychotherapy and try to address their substance use that way, and some for therapists who are wanting to work from this model.
Amazing. Thank you so much. And I know you're doing a lot of significant work, and it can be probably taxing. So I'm wondering, what are you doing to take care of yourself during this time?
Yeah, I mean, there's times where it can definitely be stressful. As many therapists are probably familiar with, you have to compartmentalize to some degree. If we were thinking about and feeling about our clients at every moment, we wouldn't be able to function. And so having ways to kind of differentiate and kind of transition from each session and each workday is really helpful. Now I've been mostly seeing clients remotely from home, so good and bad with that. But one of the goods is I have access to like exercise equipment and stuff like that. So I'll do kind of quick exercise between clients and kind of get excess stress out some. Watching good or bad television on Netflix and HBO Max and other things like that as well. And then trying to get out where I can and when I can in a safe way, whether it's going for walks later at night with my partner and things like that. So.
Awesome. Thank you so much for sharing. And if there were specific things, specific takeaways that you wanted our audience to have, what would be 3 things that you really want them to walk away with from today's discussion?
Sure. First thing I would say is everyone is a drug user. So keep that in mind. It might make you have more compassion and understanding and empathy when working with folks around that issue. And so try to not have value judgments on it. That's one. Two is trying to make sure to do your best to meet the person where they're at, whether it's around substance use, whether it's around surviving a significant trauma, whether it's around any mental health issue, rather than assuming that you know where they need to go and how they're going to get there. Trying to really sit with them, figure out where they're at, give them a chance to speak to that opportunity, go through stages of change information with them if it feels relevant. That I'd really recommend too. And three, be curious. Be curious as a clinician when working with your clients directly, and be curious as an individual and a professional in this world. Because the more you find out about this stuff, the more you're informed about the harm reduction model and the history of substance use and how it's been handled, both within this country and the world at large. The more illuminating it is to say, like, wow, we could have been doing it a much different way for quite some time now. It would have saved a lot of lives. It would have had a lot of more people feel like they were part of our larger, community, as opposed to being marginalized or scapegoated. So I'd say those three things.
Awesome. And just to recap, the movie that you on Netflix that you
it's called
reference
13th. And it's a documentary that you can watch on Netflix or watch free on YouTube as well if you don't have Netflix. So I highly recommend it. It's not the easiest documentary to watch because we've got a pretty messed up history in this country, to say the least. But it is very informative. And so if it takes you more than one session to sit through all of it, make sure you have something fun to do after. Watch videos of puppies giving rights to kittens while eating pancakes. I don't know, something, because it can be heavy. But it's definitely worth the watch.
Yes, I'm so glad that you took time to join us this evening and to discuss all of the information that you've shared, from harm reduction to, destigmatizing the work that you're doing with your clients, and how to really even kind of recognize what's going on in a client's life to be super supportive. So I really appreciate you sharing your thoughts, and it's been an amazing discussion.
Yeah, absolutely. Thanks for creating the forum and the opportunity for other people to hear and learn more about this. And thanks to everyone who showed up and took the time to listen to this. I know we have really stressful lives. And so to engage in this personal education, which is going to be also a form of self-care to some degree, and really help support your clients going forward, I commend you on taking that step too. So I really appreciate it.
Well, thank you so much. And with that, we will end this segment, and then I'll do our closing. Right. Thank you so much for everyone who joined us this evening. This has been such an amazing talk. Thank you to Laura, to Mike, to Carmen, and thank you, Justin, for sharing your thoughts, perspectives, and insights. It has been quite an informative hour. And to all of our attendees who have joined us for this 2-hour segment, thank you so much. I echo Justin's thoughts in terms of making yourself available for this and adding it to your day. I know it's a lot, but I do hope that you've been able to take away some very useful bits of information and understanding of substance abuse in our country, and how dire a situation it is that needs our support, as well as our advocacy in legislation. So I definitely appreciate all the perspectives and all the work that you do, and continuing to hold the clinical and the social justice lens. Just a couple of reminders before we completely end this evening. Just wanting you to know that our resource guide is going to be posted in the chat and on the TogetherWell website. So if there's anything that you wanted to gain access from today's talk, please definitely access the TogetherWell website if you are doing it after this event, or you can check it out currently in the chat. Additionally, you can check YouTube shortly for the recordings of this event so that you're able to watch it or share it with other people whenever you feel would be great to do so. And we want to give a big thank you to the PAD for providing such an amazing offer for virtual yoga. Remember, this is 1 month free of virtual yoga and Pilates, so definitely please see the promo code in the chat if you want to make use of that, and I highly recommend it. Also, if you're interested in working with or doing trainings or workshops for a broader community, join TogetherWell. They are an amazing organization where they help to promote clinicians who are interested in doing workshops and promoting their expertise. So join the site, and that platform will help you to reach many folks who are interested in having speakers come out and do specific talks on specific topics. So definitely take a look at TogetherWell. There are so many professional benefits. So take a look at the website just as an option. And then updates. Our upcoming event will be on Native American community and mental health. Definitely something that we need to promote more of. So I look forward to all of you joining us for this upcoming talk. See the RSVP link in the chat. Again, this is going to be on Native American community and mental health, and supporting the Native American community and understanding what their needs are and how to best support them. And then our December event is going to be for graduate students and early career psychologists. So look forward to hearing more about that on the TogetherWell website. Definitely, if you are not familiar with the website, become familiar with it, or check out their Facebook page, and I believe their Twitter as well. And then if you are going to stay on for the meditation or networking, feel free, enjoy. Definitely, from all the talks that I've done, the one thing that has stood out the most is connection. Definitely connect with other providers to just have a sense of community and to learn from each other and share your own experience as well, because that is what helps to promote our field and helps us to go farther. So with that, I will leave you and hope you all have a wonderful evening. And until next time, take care. Bye-bye.